So we are polluting our environment a lot, and we should be thinking about more green. And we talk about the radiation toxicities and prevention. So in this session, I'll be talking about the toxicities, the prevention, and the outcomes of the treatment. So with this, if you look at the, I would say my presentation can finish in 1 minute if I say brachytherapy have no side effects. I am biased brachytherapist, so anyway, then talk will go finish. No, actually, every treatment have some side effects, to be honest. So the most common side effect of the prostate brachytherapy is urinary retention. Now, one of the reason for urinary retention is actually the spinal anesthesia, because people cannot pass the urine simply, and this is for mostly for 1 day. And the way we handle it, because we do day procedure, we send the patient home. So what the way we do it, that we just put a catheter in and we ask the patient to come back next day and we remove catheter, and that usually work. So that's very simple one to handle. However, if we do general anesthesia, the chances of urinary retention is very low. Yes, for lower urinary tract symptom is more common and more common than external beam radiation. So for this reason, what we do as a preventive measure, that we ask patients to start tamsulosin 0.4 milligram, one tablet a week before implant. And then we continue as long as we think patient have regained his urinary flow. So that's usual time, is because half-life of this radioactive iodine 125 seeds is about 60 days. So we ask them to continue at least for 2 months or 2 to 3 months, and then we ask them on a trial basis to stop the tamsulosin. There are times when symptoms, some patients are more complaining of LUTs, and then in those patients, we do ask them to take 2 tablets a day instead of 1 tablet. And then as soon as the flow come back or radioactivity effects going out of the body, then we ask them to cut down the tablet. Now, gastrointestinal toxicity is not as common as like external beam radiation. Um, Honestly, when I review the cross cancer data in Canada, then I found that there was 2% of the patients who need some kind of intervention or help. But in my practice, in my own patients, I did not see anyone who have rectal bleeding. However, this is a possibility. The one what I saw is actually fistula, so rectovesical fistula in 1 out of 500 patients, and because it's a devastating side effect, we must have to inform patient possibility of this, and it's up to patient whether they choose to go for brachytherapy or not. Even though it's a rare possibility, but when it happens, it's a regrettable situation. So it's better to inform patient to make the consent decision. So therefore, I do inform them. And when did that happen, rectal fistula? Because it happened only to one patient in my 10-year stay in cross cancer. Then at that time point, we do have to do the repair surgery. And when eventually patient failed, then we have to do the colostomy for that particular patient. Now, the sexual dysfunction is one of the side effects of any treatment for prostate cancer. However, I have to say the best possibility for sexual function to retain is brachytherapy seed implant. If you look at, because there is a dose intensification involved here, Prof. Pignol and Nirmal Babu have said that we are actually giving higher radiation dose than the prescription dose, and average dose is more than 200 gray. So with that high dose intensification, most of the patients do not require hormonal treatment. And if you look at the data I presented in the morning session, where I presented about SNRT trial and Japanese TRIP trial, where they cut down the hormonal duration in even high risk prostate cancer, when they use brachytherapy as boost, and that is as radiation dose intensification, means we can cut down the duration of hormone treatment, or we may not give the hormone treatment. So whenever a patient showed me his reason or his very high interest about saving the sexual function, the best option come in my mind is do monotherapy LDR brachytherapy without hormonal treatment. So even though sexual dysfunction, I quote them that 30 to 50% chance, but actually what I would say is still this is the best option to save the sexual function. Now, the usual patient would ask me question in the clinic, how much percentage chance that I would have sexual dysfunction? So it is very difficult from the literature. If you review, it's all over the place. It's from like 0% to 100%. So you cannot give a fixed number, but I make a rough idea for you as a tip as well. That if someone asks, I say them 25% will have no effect, 25% would need the medication, and other 25% would need some more intervention like injections or other stuff, and 25% will lose the sexual function. So I just kind of divide them into four sections. It is not so simple. It depends on how much the comorbidities you have, how much sexual function you have before implant. So there are many factors, your age and many other factors. So anyway, this is just the way we can deal with it. Most commonly at our level, without referring them to urologists for any type of implant, is actually the medication which we can prescribe, like Cialis of different doses. So I want to mention here one study where I was involved, and I'm co-author in that as well. And it's actually attracted the publication in JAMA, which is high impact journal. So I definitely want to mention here, there are many people who are believing that if we give Cialis in low doses as prophylaxis, their sexual function will retain more than if we give that tablet when there is a need. So we did that randomized study, and that randomized study was blinded, and we found that actually prophylaxis of Cialis did not have any impact. So I just wanted to mention you because you don't have to spend money on those tablets for no reason. And you can actually consult that. You can read the article RTOG 0831, which published in JAMA. Now, the one of the other issue can be the seed migration can happen. Now, the seed migration, it is less and less now because we are using stranded seed. Before we were using loose seed, and sometimes loose seed will come out, and there are different ways come out. It can come out in the urine, it pass into urethra and pass into urine. And when you found that in your toilet, you don't have to panic for radioactivity. All you have to do just flush your toilet twice, and that's it. So that's one direction. The other direction, it can go into the blood vessel and circulate, and it go into your filter area, which is your lung, and it is stuck there. We were in the past taking the chest X-ray, and rarely some patient will have the seed in the lung. We have to do nothing. It doesn't harm anything, but we need to inform the patient for not to panic some other physician or institution in future if they do lung scan, so they should know there is a seed there. So that's with the stranded seed use that gone out. There's not much of an issue. One time in my entire practice, which was like 10 years of practice, I come across a situation where I puncture into the bladder, and then even though I corrected my position, but somehow there was a hole created, and the whole entire strand was sucked into the bladder because of negative pressure. It goes into the bladder, and I was panicking. But when I sent him to urologist, he said there is nothing to do, and he actually didn't even remove the whole strand, and the strand eventually come out. So it's very, very simple. So seed movement migration is not an issue. Now I'm just presenting Cross Cancer Institute toxicity level, which I come across when I was working there, just for you to have an idea. So urinary retention was in 16% people, or about 15%, you can say. That's for one day. We put the catheter and were done, and most of them were actually the spinal anesthesia patient. And then very few other side effects like TURP we have to do in 2% of the patient. Minor TURP procedure is not only TURP, is included the laser fixing for because of the urinary symptoms. Rectal bleeding, as I mentioned, 2% of the patient. I did not experience in my patient because this was the data we collected over many years. So maybe in the beginning we have learning curve and we may have more of issues than later. And rectovesical fistula, which I told you that I saw in my time of practice in one patient. So I want to tell you that how to prevent the urinary symptom is the most common symptom in the prostate brachytherapy patient. Now, can we do something about it? Now, we can do something and we cannot do other things because urethra is passing through prostate, which is our target, and we try to protect that. Brachytherapy gives the most heterogeneous dose because of that to protect the urethra, and it does good job for that, but still there are side effects. So you can see this MRI scan where there is external sphincter is shown, which actually can be affected by the brachyseed implant. So we can prevent that. How? So what we are doing in our center, we most of the people are planning on based on ultrasound only. But we are actually planning on the base of both ultrasound and MRI. Fortunately, we have an MR simulation. So we do MR simulation for every patient, and we fuse the image with ultrasound. And based on ultrasound and MRI, we were very careful about where our apex area is. Because if you go beyond the apex area, there's more chance of urinary toxicity. And there are some data you can see in here. I don't have to repeat the numbers. You don't have to remember them all. The main thing is if we can prevent the extra doses to the area where the apical part of the urethra is membranous urethra. If we can save that, that can reduce the urinary toxicity. The other thing which is I must discuss here is rectal spacing. One of the most challenging organ for us in external beam radiation is actually the rectum, not so much in brachy. However, there is a situation where I think it's very important. When we do salvage brachytherapy, where patient already have external beam radiation affected their anterior rectal wall, and now we're going to do the brachyseed implant to full dose. So we're talking about full dose of external beam and then full dose of brachytherapy. Of course, it's challenging and it's a lot of radiation. So for those patients, I do feel that I must do rectal spacing if opportunity is there, or if the procedure is available. So with the rectal spacing would not be done before implant. If we do before implant, then the arch will be an issue. The prostate will be pushed towards anterior, and then we will have challenge to face with the arch. So we could do implant first, and once we finish the implant, we can actually do the rectal spacing there. There are a couple of methods, space OR and hyaluronic acid. Very simple procedure. Anyone who does the brachyseed implant or HDR brachy, it's very easy for them to quickly learn about doing the rectal spacing or transperineal biopsy. So that's another area we can improve on the side effect. I will move on to the outcomes of the treatment. I just show you this slide, which that Dr. Peter Orio have shared with me, that when we do the biopsy of after the high doses of brachytherapy or after brachytherapy, so there were some low quality implants, as Nirmal explained about the quality of implant. If the quality of implant is low, the risk of percentage of positive biopsy is about 30%. So it is very important when you do the implant to be a good quality. Fortunately, all our patients we did in our center were good quality implant. But when the doses are enough, like even if your D90 is actually between 116 to 160 gray, like even 160 gray, 16 gray, we do target more than that, and we usually get more than that. Is still the biopsy positive rate bit lower to only 6% and can down to 4% when we do good quality implant. So this biopsy positivity shows that the effect of the brachyseed implant. So it's actually good way knowing the outcomes. I mentioned that in the first session as well, and again I bring this Grimm's data from Seattle. Cannot skip that. There is no hand-to-hand. There is no randomized comparison of radiation, external beam, brachytherapy versus surgery, or EBRT plus brachy and brachy. So there is no comparison. So he did the plot of all the patients who received all different type of treatment, and you can see the brachy is standing out very well, very clear. So the outcome in Grimm's data is that brachy is quite standard, at least as good as other option or even better. And also to remember, when we do surgery, about 1/3 of the patient would require salvage radiation treatment, and having the side effects of both radiation and surgery, and outcome is similar as brachy alone or only brachytherapy. So keep these things in mind when you discuss or offer the treatment options to the patients. So if I move on to that was for the low risk and intermediate risk. Now I'm moving on to high risk patients. So I said that before in my first session, and I'm repeating that here again. I don't know how would a center now will justify not having the brachytherapy. I know many center in our region do not have that, but imagine if I tell you that gynae brachytherapy, gynae treatment services without brachytherapy? Not possible. So not that much, but coming close to it, because now Ascend RT have reported from Canada a randomized trial where a patient were treated with external beam radiation compared to external beam for microscopic level of disease like elective doses, and then give the boost from the prostate brachytherapy LDR. And in this randomized trial, you can see the graphs very clear. And I said that I can easily pass through between these two graphs. So it's very clearly in favor of brachytherapy. They reported the long-term data as well, and that's actually showing us the better outcomes in the long run as well. We do know that the urinary side effects were slightly higher. However, the outcome of cancer is better. And if you look at, the patients who have higher Gleason score, they have extra advantage of doing the brachytherapy. I think this is because of the dose intensification. And we should not forget here is not only comparing to external beam radiation. External beam radiation, we have given hormone treatment for 2 to 3 years. And when we have given 2 to 3 years hormone, when we stop hormone, it take about another similar time duration to recover from in the testosterone. So we are talking about hormone suppression of somewhere 4 to 6 years. So of course, after 6 years, most of the people most of the study they don't report after 6 years. They report after 5 years, and we don't know how much failure happened. So by doing this treatment in this Ascend RT trial, the hormone treatment duration was only 12 months. So we cut down the hormone treatment to half the duration or even less. So if you are comparing external beam radiation and hormone duration short, then this is giving you brachytherapy an advantage because of dose intensification. So I would say even high risk, we need to treat them with the boost treatment with brachytherapy. And this will be another separate debate whether we do that with the HDR brachy boost or LDR brachy boost. We are learning every time with the newer studies. So as I mentioned that of course the GU toxicity was higher in the Ascend RT with the brachy boost, which is quite expected. Also the boost dose for the Ascend RT was a bit higher than some other studies. It was 115 gray. I would say that most of the centers are doing 110 gray for LDR brachy. And if they use HDR brachy, they give 15 gray single fraction before or after external beam. But something interesting is that we may think that dose intensification help only in the high risk. So that's not true. So if you look at separately the data of intermediate risk, that also shows benefit by doing the LDR boost. However, there's another study RTOG published where they compare only monotherapy of LDR brachytherapy with external beam, elective doses, and then boost brachy, and they found the outcome is similar with less toxicity in only brachytherapy. So I would not recommend you to do intermediate risk prostate cancer to follow Ascend RT protocol, because only brachytherapy seed implant as monotherapy give you same result without increasing toxicity. So I'm very clear about it that what I'm talking here is high risk prostate cancer treatment and a tri-modality treatment where we are giving external beam radiation on elective doses and then boost by brachytherapy, and separate debate for whether the LDR brachy or HDR brachy. When we pass and some new studies will be reported, we will get these answers. But shorter duration of hormone treatment. So I'm coming to now the salvage brachytherapy. So I showed these slides before as well, and I'm repeating that RTOG 0526 study. I was part of it and I'm co-author as well in that one. So I got lots of learning while we were treating the patient and writing the manuscript. And we found that when patient fail focally only in prostate gland after 2.5 years of radiation treatment, external beam, and they have no other distant metastasis, salvage treatment with brachytherapy seed implant has given them a good chance of salvage for up to 61% at 5 years' time. So this is a very good result in my opinion, and is comparable and actually have an advantage over other option of salvage treatment. So this was the outcome I want to discuss about the salvage patient, which was after the failure of external beam radiation. you must be interested in that how much will be the toxicity. So grade 3 generous RTOG based toxicity scoring was maximum grade 3 to 14% of the patient. But most of those toxicity after 2 to 3 years, if they have it, was actually improved. So we talk about what should we do about some tips and tricks. There are many, some in my mind I wrote, which was in my mind. The one which is not in my mind, if you have any question, you can always ask in the question answer session. We have a bit of time as well. So brachytherapy, as I mentioned to you, is a dose intensification. And we can create a cool plan and a hot plan. This was my learning after some experience. So the people, when I was using the both salvage patient where they already have external beam radiation, I was using a cool plan. In the beginning, I did hot plan and I learned more toxicity in those patients. And when I did the cool plan, it reduced the toxicity, but at the same time, the outcome was so very good. The cancer control rate was not different. And Prof. Pignol have showed in his plan that how can you make a cool and a hot plan. And also Nirmal Babu mentioned that, he may be not very happy now, but he spill out in his talk that I do extra seats in the plan. And then that make the plan as hot plan. But those are not the salvage case. I did not, he can confirm me that I did not put extra seat in the salvage patient where the external beam was already done. So we do order extra seats, and I tend to, as a physician, I tend to put extra seats. Yeah. So that what we can do is that by using for the booster the tumor area. Then we go to the next point is that if we use the catheter for the urethra localization that affect the images, so it affect the images, and also it actually distort the urethra. So urethra distortion actually then is not the actual urethra, which the patient will be receiving radiation to. So I personally don't like to put the catheter into the ureter. And what we come out, we were using that, and probably we get it from the Seattle center, and we were using in cross cancer, and we are using in Oman as well. Is that we use KY gel 1/3 and KY and 1/3 of air and 1/3 of the water or saline, and we mix it. And when we thoroughly mix it, it make white bubbly liquid solution, which actually we push into urethra and clamp it for the duration of implant, and it shows very bright urethra. You cannot miss, and it does not distort because natural. It follow natural. So that's one of the trip which you can use when you are going to start in your center. Then there are for the salvage treatment, there are debates going around in the world that whether we do focal brachytherapy or we do whole lobe brachytherapy or we do a whole gland. In my experience in our region, patient usually present a little bit late, and I notice that those are usually the whole gland is already involved. So the salvage I did in here in my center is that have to be actually implant in whole gland. So, but however, if you find the biopsy proven or MRI based localization, then you can think about focal or lobar implant or HDR or versus LDR. MRI, I mentioned that that we have MR simulation. We do MRI for image fusion, image registration, and that's give us added benefit, and we can save also sphincter as well. So the urinary symptom is lower in our patients we mentioned. But when you use the CD from some other center, from diagnostic, they usually take the oblique images, and you cannot depend on those image fusion because they are inherently larger in size, and that would confuse you. We have gone through for one patient already here and learned this on the hard way. So just to let you know that diagnostic imaging sequences may be not the same as ultrasound. So be careful when you use MRI fusion, and if it is not MR simulation and axial straight cuts. So there is so the other thing is that when you have the brachy setup, now we are coming close to our talks, and our aim was to why and how you can have the brachy setup in your center. So I can tell you some extra advantages of having the brachy setup. So if you have brachy setup, the same setup can be helpful for you to start a transperineal biopsy instead of transrectal biopsy. So the one which the physician who do the brachytherapy, this is a very easy job of doing the transperineal biopsy. We can put fiducial if you want to use the cyber knife in some center and you need fiducial. If you are a brachytherapist, fiducial marker is very easy job for you. Also, we just discussed about the rectal space and spacer, and we talk about if you are brachytherapist, again, transparent biopsy, fiducial, or rectal spacer is easier job for you. So if you have the setup in your center, you get these things as additional as a free in the package. For the tissue biopsy, so there are studies when you do the studies, they do require sometimes tissue sampling, and those tissue sampling is enormous advantage to your study because you can do molecular studies in those patients. Normally or generally, we don't go and do a biopsy for the prostate for a study purpose because that's an invasive procedure. However, if you're doing brachytherapy, it is easy for you to take a sample of tissue at that time for analysis. So that is another advantage. And I am coming to close to my talk, but I just want to show you that where I came from in Edmonton, in Canada, Alberta. And this is the situation there right now. So there's huge issues. People, cars are stuck, cars are broken, pipes are burst, and difficulty in going to work, school have to be closed. So this is the situation in Alberta, where I come from. If you can find your car, you can drive, but you have to find and dig out your car. And here is other area, if you look at, these are the pictures from my phone. So here you can see nice, beautiful waterfalls and ocean, and you can this right bottom corner picture is actually under the water in the sea. So you can see how transparent, how clear the water is for snorkeling. That where you can see everything to the bottom, and the right upper corner is a sunset in the desert. You would love all this. Trust me, Bean, I enjoyed all of this, and it's actually very, very amazing. You can write down in question answer about your comment. If I give you two choices to live, where would you prefer to live? I would like to hear from you. And with this, my talk is completed, and I'm before time. We can, and I don't see any question answer. I will check before I pass on mic to Miss Iqbal Al Amri, who is our